it's Dr. Stanwood. I'm going to be talking to you about a couple of things today, osteoporosis and Pagets disease. I'm excited to talk to you about osteoporosis because it is one of the things as an endocrine nurse practitioner I get a ton of consults for. And I feel like primary care should know how to manage osteoporosis and they're not comfortable with it. So I just really hope that you learn something and you get a better handle on who to screen and how to make decisions surrounding bone health. So osteoporosis is essentially weak bone or a susceptibility to fracture. The World Health Organization defines bone mineral density based on standard deviations, or what we refer to as T-scores. So if you've got a patient that you want to order a bone density test on because you're worried about their bones, they are going to give you a report that has T-scores. And your T-scores, if they are above a negative 1.0, that is considered normal bone density. If they are below a negative 1.0 to a negative 2.5, that's considered low bone mass. We used to call it osteopenia. I still refer to it as osteopenia, but the terms are changing. And then if it's below a negative 2.5, it's considered osteoporosis. And typically we refer to the International Society for Clinical Densitometry has recommended that the definition be applied only to postmenopausal women and men older than 50. Okay, so osteoporosis is typically clinically silent unless a fracture is noted. Many times it's discovered on other imaging, and you may need to then, you'll get a report because you did some sort of an x-ray and they will say, we see osteoporotic bone. Typical fracture sites are the vertebra, the distal wrist, the proximal femur, and the ribs. Osteoporosis occurring in men and postmenopausal women or perimenopausal women should lead to a condition or a consideration of secondary causes. I will never forget when I was a very new nurse practitioner and somebody had osteoporosis and I just put them on treatment. And I remember getting this letter in follow-up from, like the neurologist who have sent them and was like, what is this person's cause or reason for having osteoporosis? And I just remember being like, oh geez, and I was in a little bit of a panic. So you always want to think it's not normal to lose bone and you should work up secondary causes. So you want to screen anyone with a fragility fracture. Fragility fractures are my nightmare because I really struggle sometimes. I've been doing this for years and years and years. And I typically struggle with whether or not certain things are fragility fractures. I get referred out from orthopedics a lot saying this person had a fracture and it probably, they fell from a standing height. They probably shouldn't have fractured. So then I do a bone density, evaluate them and determine whether or not they need to be treated. So if you've got women over 65 years old, they need a bone density. If they are under 65, but they are at increased risk, like let's say early menopause who are never treated with estrogen, or if they are on chronic steroids or something, maybe they're a very heavy smoker, or they're anorexic, or they had a history of long-term eating disorder. Those are people, we do bone densities on our bariatric patients who have had, we do one every year on anybody who's had gastric surgery because the malabsorption they're at risk for can weaken their bones. So a fragility is basically defined as something that results from a mechanical force that would not normally result in a fracture. And the World Health Organization has quantified this as forces equivalent to a fall from a standing height or less. And I got to tell you, it's never that simple because, I had a guy who, like if they slip on the ice and they fracture, is that normal? Is that a fragility fracture? Well, how much does the person weigh? If they're 400 pounds and they fall on their wrist, it probably was supposed to break. So really determining whether or not they're a fragility fracture, because if the bone density is normal and they have a fragility fracture, they still have osteoporosis. And that's where it gets tricky. So what do you ask? You're seeing these patients, you've got concerns about osteoporosis. Your secondary causes are going to include smoking, alcohol use. They say greater than 3 drinks per day. GI issues. Do they have celiac disease? Do they have any malabsorption disorders that would cause problems? Are they on chronic steroids? Now, if they were on steroids for a week, that's not the people that we're talking about. If they're on steroids for more than a month, especially more than 3 months, you want to consider assessing their bone density. Now, you guys are going to ask me, what if it's a 40-year-old or a 35-year-old who probably doesn't have bone loss? If they are on chronic steroids, I might get a baseline bone density and then repeat it every few years to just make sure that the steroids are not doing damage. And then at some point I might have to treat. If they've had GI surgery, like I mentioned, celiac, or if they are somebody who has a decreased dietary and calcium and D intake. So check your labs, calcium and vitamin D, and make sure that they are replete. On your physical exam, go ahead and palpate the spine. Look for kyphosis, which essentially are, your spine are supposed to be little rectangle discs. That's what I envision them looking like. And when somebody gets kyphosis, part of that rectangle has broken down and now it's angled. And when you get a whole lot of those compression fractures along the spine, people start to develop kyphosis. And so, the only thing, you can't fix kyphosis unless they go in there and do a vertebroplasty where they inject cement in and build it back up. But your goal is if you start to notice kyphosis on an exam, that you catch an osteoporosis before it gets worse. Okay, let's talk about this bone density test. It's a pretty simple thing. You just order it. In somebody who you have on treatment and you're monitoring, typically we do one every 2 years. In somebody that's very high risk for rapid bone loss, we typically do them every 12 to 18 months. If you do your bone densities too close together, you're not going to see any difference. It takes a while to see change with bone. And so you really want to wait the time needed to reassess your treatment. I apologize, this is a very small report, and it was the one I could find when I was doing this, but and I don't know why it's printed in black, white on black, etc. But anyway, when you order a bone density, you're going to get a report, and the report is going to look something like this. Most likely, the radiologist or the tech will have administered a questionnaire, and we're going to talk about what that questionnaire means, but we refer to it as a FRAX calculation. And basically, it's a series of questions that are asked, that are input into a calculator and determine a score, which is essentially your risk of fracture. So let's look at this report here. What you're going to see is it's going to tell you what the score is in the hip, and this is telling us that the mean total hip score is a negative 2.8, and I apologize, I missed the spine. And it's going to tell us the spine score. So the spine score, L1 through 4, is a positive 0.3, so we don't have any osteoporosis there. In the spine, because in the hip, because the hip is lower than a negative 2.5, it's consistent with osteoporosis. Now, the radius is completed in certain situations. The radius is not a good place to measure, to compare bone densities, but oftentimes we will check a radius when one other site is unavailable. So typically on your bone densities, you are going to get a spine score, you're going to get a total hip score, and you're going to get a femoral neck score. If there is osteoporosis at any of those sites, you have osteoporosis as a diagnosis, even if it's only at one of the 3. If it's only at the radius, and you still have osteoporosis, but we don't typically use the radius to compare treatment, like I said, but oftentimes it's included if something else gets thrown out. So let's say you've got a patient who has a bunch of hardware in their spine and they can't use the spine. They really want to try to assess at least 2 areas before you can, I believe the rule is you have to have at least 2 areas on a bone density test to be able to report it. So what we've got here is osteoporosis. We're done. We've got our diagnosis. Now the FRAX score, we can look at it, but we've already got our diagnosis. What FRAX does is it's this tool that was designed, and let me see if I can, let me go to the picture. Okay, I'm jumping ahead really quick. This is our FRAX tool. So as you can see, it's a tool that asks a bunch of questions about their bones. So what is their age? What is their sex? How much do they weigh? How tall are they? I'm sorry, this is kind of a difficult picture, but you can Google it. It's going to ask you, are you a current smoker? Are you drinking alcohol? It asks you all those questions. You put it in. It's also going to ask you to put in a portion of your bone density test. And you kind of get to pick what you use. So if you want to use a T-score, it's going to tell you that it wants the femoral neck T-score. You put it in and it's going to give you a score. As you can see here, it gives you the 10-year risk of having a major osteoporotic fracture. And then it's going to give you the 10-year risk of having a hip fracture. Each country has different parameters for what they determine to be normal within these numbers. So in the United States, if your 10-year risk of having a hip fracture is greater than 20%, treatment is recommended. If your 10-year risk of having a hip fracture is greater than 3%, treatment is recommended. But you don't have to use FRAX if you've already got a diagnosis of osteoporosis. FRAX is best utilized when you have osteopenia. So in the old days of bone density treatment, we used to put everybody on a bisphosphonate with osteopenia because we were so worried about bones. And we are still worried about bones. But the issue is the drugs have side effects. They can't be used for long periods of time. And, we decided that we don't necessarily need to be using them in patients who are low-risk osteopenics. So if you've got a diagnosis of osteoporosis, you really don't need to look at FRAX. If you've got a normal bone density or you've got osteopenia, I want you to double check your FRAX score. If your FRAX score is above those criteria we talked about, we recommend treatment. So here, this patient, their 10-year probability of a major osteoporotic fracture is 12.8%. They do not meet. Remember, it has to be above 20. And their 10-year probability of a hip fracture is 6.2%. That does meet. So either way, we have criteria to treat. Let's look at what a bone density looks like. I have stressed this to you guys before. Look at your imaging and teach yourself how to read your imaging. There is not nearly enough time in an NP program to give you thorough reviews of all of the imaging out there. So you're going to have to learn a lot of it on the job. What you want to do is look at your imaging. When you look at a bone density, there's a couple of things I want you to be sure of. Now, typically what we say is that there are these things called ROI lines. I'm trying to remember what they stand for, but the mechanic or the tech will put these ROI lines, these yellow lines, around the bones, and they're used kind of as measurement markers. And then this big box is put up here, and you want to make sure that the tech put it in the right space. Like, you want to make sure that L1 is really where it's supposed to be. Well, how do you do that? What you do is you look for this prominent rib on the bone density, and as long as L1 is right below that, the scan has been lined up right. I can tell you, I have seen some funky bone density tests, and when I go look at the imaging, this square was put on the incorrect spine, which is why I had such variance among my 2 bone density results. So if you get a bone density and it's vastly different from the last one and the patient's on treatment, make sure that the ROI lines were placed correctly. Now, sometimes what you will see on these bone densities is that one of these vertebrae may be removed, and it'll be lightened out here, so you won't see the number. What that means is that they have eliminated that portion of the spine because either there is hardware in that area or there's so much degeneration that it's not something that they can accurately read. So I'm going to get a little complicated here. If you don't remember it, I just hope that you remember you learned something about it. When you are looking at the spine, there's 4 vertebrae that they use, and it's L1 through 4. What's going to happen is you come over here to your L1 through 4, and you're going to look at your bone mineral densities, okay? Normal spine bones should get bigger as you go from L1 to L2 to L3 to L4. So you want to look and see, does my spine get bigger from L1 to L2? No, it actually gets smaller. But from L2 to L3, the bone mineral density gets bigger. And then up to L4, it gets bigger again. So one of the concerns I have with L2, with this drop down in L2, is maybe there's a compression fracture at L2 that I'm missing. Now, when you go over here to the T-scores, you can see that I know this is getting a little complicated and you may not need to go this far for primary care, but when you're looking at your T-scores, you want to make sure the radiologist threw out or included the appropriate vertebrae and that they didn't inappropriately include any. So if you're looking at your 4 T-scores and you've got any that are more than 1 standard deviation away from the other, you need to throw it out. You can only report the spine. You have to have at least 2 vertebrae that are available to review in order to report a spine bone density. And those 2, so here, if you see from L1 to L2, we've got 0.4 and a negative 1.4. There's about 1 point between them, so that one's fine. And then between the next 2, there's about 1 point. L3 to L4 might be a little funky, but essentially there's about 1 point difference between all of these. It can be closer, but it can't be farther away. So basically what I'm saying is that as long as there's, like if you had one here that was a -3 and the rest of them were 0.4, 0.4, that one is really off compared to the others and you want to throw it out. If you've got 2 that are off and 2 that are like pairs of 2 that are both close together, you want to use the pair that is the lower bone density score. Don't worry if you forget everything I just said. It's just an extra way to check and make sure that your bone density was done appropriately. When you're looking at the radius and the ulna here, essentially, the big thing is just looking to make sure your lines are placed correctly, and then essentially you're looking at your T-score of the radius and your T-score of the ulna, and that's pretty much all you have to do. Oh, didn't I have a hip in here? Darn it, I forgot my hip picture. So for the hip, what you want to do is, if you envision a hip, there's the lesser trochanter. You essentially want to look at your ROI lines on your hip film, and you want to make sure that the patient was rotated correctly on the machine, and basically that means you shouldn't see much of the lesser trochanter. So I apologize for excluding that picture. Okay, one of the things that you're going to potentially start seeing on your bone density reports is something called a vertebral fracture assessment. I do not get these on my current bone density reports, and I wish I did. These are really helpful in those people who don't look like they have bone loss on their bone density scan. So our patient that we just saw, when I said that there was that L2 that looked like it was going down in density versus up, and I was worried about compression fractures. Well, while the patient's on the DEXA machine, the radiologist can add to that bone density what's called a vertebral fracture assessment. And basically, it's an image of their lumbar and thoracic spine. And they can look along here and see if there is a fracture. And if there is, obviously that's more concerning and consistent with osteoporosis and may make you want to strengthen your treatment. So indications for a vertebral fracture assessment, typically they say ask for one in women that are over 70 years old or men that are over 80 who are complaining of height loss or you have noticed height. It's very important with osteoporosis patients that you get a height every time they come in. If they have a self-reported history of a possible vertebral fracture, or if they have been on glucocorticoid therapy equivalent to greater than 5 milligrams of prednisone per day for greater than 3 months, that's when we're worried about these fractures. So, 5 milligrams of prednisone, like I taught you guys in the adrenal lecture, is also equivalent to 20 milligrams of hydrocortisone, which is mostly what you will use. But these are indications where so again, people have a T-score of less than 1.0, so their bones don't look horrible, but you're really worried that they might have something else going on. Ask your radiologist if you can add a vertebral fracture assessment on to their bone density, or you just get spine films. If it's too late, you just get spine films. Okay, we already talked about fracs. Part of the workup, so we want to look for secondary causes, and what I typically do is I start with the basics. We start with a calcium and a vitamin D. I do a PTH level. So if you recall during one of the parathyroid talks, if your PTH level is high, that is usually driven by low vitamin D or calcium. So if the patient has normal calcium levels and normal vitamin D and their PTH is elevated, that could be a sign that it's not enough. Even though the labs are normal, it's not enough for them. I'm going to strain your brain here. Oftentimes what I will do, if you want to know if they're getting enough calcium, do a 24-hour urine calcium and see if they're spilling calcium into their urine. If their serum calcium is normal and they've got the presence of urinary calcium, they're getting enough calcium. If they've got a normal serum calcium and a low 24-hour urine calcium, they're not getting enough calcium. So that's one way to kind of determine whether the patient is getting enough. You don't typically do a 24-hour urine for vitamin D. You just look at a vitamin D level. That's pretty simple. If somebody has really bad bones, you want to think about sex steroids, estrogen and testosterone. Typically, bone loss due to lack of estrogen and testosterone or your sex steroids will be seen in the spine. If you've got a bone density come back or you've got a bunch of spinal fractures, it's likely due to estrogen and testosterone deficiency. And, whether or not you can replace those, that's a whole nother lecture, but it's something to think about. You want to check your thyroid studies. The hyperthyroidism can cause bone loss. In many cases, I will do a celiac screen, especially if I suspect malabsorption. We recommend a serum protein. I don't do protein electrophoresis or urine electrophoresis right off the get-go unless I'm concerned about non-parathyroid mediated hypercalcemia. ESRs I don't get. I honestly don't get the rest of those. I just start with your basic calcium, vitamin D, maybe a urine calcium, etc. And then osteoporosis pharmacotherapy. Sorry about the lack of space. So when you're ready to treat your patients, you've got to now decide, what am I going to treat them with? Well, typically the mainstay of treatment is bisphosphonates. So bisphosphonates are drugs that help regulate the osteoclasts when they get out of control. And they're typically used first line as long as the kidneys are normal. If the patient has severe osteoporosis, I am going to jump to an anabolic agent first, such as teriparatide or abaloparatide. And that's typically my guide for that, is if their T-score is, their starting T-score is lower than a negative 3.0, I am going to start with an anabolic agent before a bisphosphonate. But you guys, you can start bisphosphonates. You do not have to send them to endocrine. You basically are going to pick one. I use alendronate, 70 milligrams weekly, and you just start them. If they have GERD, so if they have any GI issues or they're for whatever reason going to forget to take a weekly pill, then you can you can give them zoledronic acid. So zoledronic acid is essentially a bisphosphonate given IV, and it's great. They come in once a year. You give it to them for 3 years in a row, and then you reevaluate whether you want to continue the treatment, switch them to something else, but you kind of treat for 3 years and then reevaluate. Anabolic agents really build bone. So like we talked about, those are strong drugs. They're injections that are given once a day, and we treat for 2 years. There is not any data that says we should treat longer. So typically in somebody with severe osteoporosis, we'll treat for 2 years and then put them on a bisphosphonate, assuming that their kidney function is normal. Rank ligand inhibitors have come out. The one that we use is denosumab. It's great because it can be used if there's kidney disease. It's an injection given once every 6 months. So in somebody where a bisphosphonate might be contraindicated, it's very important. Or if you've got certain patients high risk for fractures, such as older patients who have difficulty with the dosing requirements of a bisphosphonate, or they've got really bad kidneys and can't do zoledronic acid, denosumab's a great drug. It's got good data. Sclerostin inhibitors are relatively new. I'm going to be honest, I've never used one. I work at the VA. They're not available yet. I'm a little nervous about these. Romosozumab is our first one. They're pretty exciting drugs that do a really good job. They're very good for patients who have multiple fragility fractures or those who are at very high risk for fracture and cannot tolerate any other therapies. We typically don't use them first line. There is some, in the clinical trials for romosozumab, there was some concerns regarding statistically significant cardiovascular disease associated with them. So if anybody is at risk for that, you would definitely want to avoid that. You know, calcitonin comes up here and there. I have probably used it once in over 15 years for bones. It's a short-term treatment that is often used for somebody with severe bone pain related to like a spinal fracture, but I just don't find it that beneficial. There's also the SERMs, which I forgot to include in here or failed to include, the selective estrogen agents, and those are great because they essentially help you build back up some of your estrogen. But if you've got somebody who's at risk for or use estrogen as a contraindication, then obviously you don't want to use that. So let's talk about foods and drinks with calcium. So what I tell my patients is I want them to get at least 2 servings of calcium a day. If they get it in that meal, and it's a significant source of calcium, then they don't have to take their calcium supplement for that meal. If they don't get it in that meal, they need to take a calcium supplement. So this is a chart that kind of gives you an idea of how they can get calcium. So 8 ounces of milk gives them about 300 milligrams of calcium. If they are using the artificial milks like almond milk and stuff like that, it just doesn't give you nearly as much. So you really want to make sure that they're doing cow's milk. Yogurt is a great source, 6 ounces. Orange juice, make sure it has calcium. Tofu with calcium. Cheese, you're looking at about 1 ounce, etc. So you can, I will often print or email them this list and help them get some more calcium in their diet. If not, then I'm going to put them on a standard calcium supplement. Okay. So monitoring your bone density patients. Well, you want to monitor their calcium and vitamin D and make sure they're replete. Sometimes I do start high dose vitamin D. If I've got somebody whose tank is pretty darn empty, like if their vitamin D is under 10, I am going to use ergocalciferol. It comes in 50,000 international units, and typically I'll start with once a week dosing, give it to them for 3 months, and then recheck a vitamin D, and then I will put them on standard cholecalciferol vitamin D, which is just D3. So ergo is D2. It comes in high dose. When you're looking at vitamin D levels, just look at the total. You don't have to get wrapped up in the D2, D3 levels. But when you're replacing high dose D is D2, it doesn't matter whether you give them D2 or D3. Just give them D and get their level up. And then monitor that level. A urinary NTX is a great tool to use to see if they are absorbing their bisphosphonate. So urinary NTX is essentially a marker of bone turnover. When somebody is on a bisphosphonate, their NTX, typically it's supposed to be done as the second morning urination, and their urine NTX is going to drop with treatment. So if you've got somebody and you're just not sure if they're truly taking their pill, or you're not sure if it's absorbing because you're looking at a repeat bone density and they're not getting any better, check a urinary NTX. And if that NTX is in the lower half of a normal range, they're probably taking it and getting it. If it's in the upper half of the normal range, they're not absorbing it. Whether they're missing it, you're going to want to switch to an IV form or to another drug. Okay, I hope that was helpful. I think that's the gist of it. We're going to move on to Pagets disease, which is pretty quick. So Pagets disease is typically something, it's rare that you're going to see somebody with bowing of the leg. Essentially, Pagets disease is an overgrowth of bone. It's the second most common metabolic bone disease in older adults, and basically it's an increase in bone turnover. And so you see some people actually have, like you see in this picture, excess bone. Oftentimes that bone that's made is weak bone, and it's not strong bone, and it fractures easily. It's the way I honestly think you're going to see it is you're going to get labs and you're going to see an elevated alk phos, and you're not going to know why. And the person you're going to have to work them up for Pagets disease, and they're not going to know they had it. So basically, essentially Pagets disease is where osteoclasts in the infected area are increased in number, size, and activity, and cause a breakdown of bone at a great speed. So then your osteoblasts are building up, and it's just a rapid process. So what is the treatment? Bisphosphonates. We turn that osteoclast down. So like I said, you're probably going to get somebody. I get these consults all the time where people didn't know they have Pagets, and they send them to me because they've got an elevated alk phos level. So what do I do with them? Well, you want to know with your alk phos whether it's coming from bone or whether it's coming from your liver. And the first thing that guides you in that direction is your GGT level. If your GGT is elevated, there's a good chance that alk phos has nothing to do with your bones. If your GGT is normal, then there's a chance that it's of bone origin. And my next thing, so Pagets disease, there's certain areas that are more susceptible to overgrowth by Pagets, and it typically is the skull, sometimes the jaw, the long bones, and the hips are usually the areas that you'll see it in. So what I'm going to do, if I suspect Pagets, I've got an elevated alk phos, I think it's bone origin, you can get a urinary NTX. It will be elevated typically, and I'm going to get a whole body bone scan. And this is going to light up all the pagetic sites on the person and help me then determine whether or not I need to treat anything. Now, I really wish, I don't know if I did a good job of giving you guys the symptomatic versus asymptomatic, but we're going to talk about that. Some people, there's a serum bone specific alk phos, which is what I use. Some people also use the serum amino terminal propeptide of type 1 collagen, also referred to as a PINP. But basically all of these are bone turnover markers. I do a bone scan to find the pagetic areas. As you can see, they light up as in this person's knee. And then there's also, you're going to get normal radiotracer uptake in the urine because that's how it gets out of the person. But there are certain pagetic areas that you will see. So in this patient, you can see uptake in the fibula and the vertebra on the right, it says. So I think it's trying to show us this area here on the film. My picture's a little cloudy, so I can't really tell all that well. But anyway, the reason to identify the sites is because then what you can do is you can x-ray through those sites and see if there is any fracture or any problems. The next thing you're going to do is determine whether the patient's symptomatic or asymptomatic. If they have Pagets and you've done a bone scan and they've got Pagets of their hip and they have no hip pain, that is an asymptomatic patient. You do not necessarily have to treat asymptomatic people. They can just run these high alk phoses and be fine. If they are symptomatic, that might be tender to the touch, I've never felt increased pulsatility over the affected bone. And I think a lot of times when we get images on these, I don't see deformed hip bones. A lot of the Pagets I get is asymptomatic. And so I don't get those really big bowing things. They may have an enlarged head with frontal bossing, as you can see seen up here, or they may have trouble with their jaw. As you can see in this picture, this person's jaw is lighting up. There you can see that their jaw is overgrown. So this is the difference. Pagetic disease is something, hold on one second, let me just tell this person. Okay, Pagetic disease is, if it's asymptomatic and you decide not to treat it, then you can just monitor it. You can monitor the alk phos, it's going to be up, but more so you just want to monitor the person for pain. If they have pain and you want to treat it, oftentimes one dose of zoledronic acid will treat them for the rest of their life. I like to treat areas. Now, if I had somebody with Pagets of the jaw and it wasn't bothering them, the jaw isn't an area that's susceptible to fracture. Whereas if they've got Pagets of the hip, I'm definitely more likely to treat that because that's going to be weak bone. They could fall on their hip and easily fracture. So I would give them zoledronic acid. With our Pagets patients, you want to do elemental calcium and vitamin D, and then focus on fracture prevention. I tell all of my bone patients, your one job is to make sure you don't fall. Move slowly. If there's things in the house that you're constantly tripping over, you need to get those out of the way. Okay? And as long as the alk phos stays normal, the disease is in remission, which is great. So that is all I have for you today. I hope you got something out of this, and I hope you guys have a great one.